The onset is typically marked by hypertension and edema, with proteinuria appearing several days later. Headaches and visual disturbances may follow and are indicative of severe preeclampsia, often requiring delivery. Eclampsia is heralded by more severe central nervous system involvement, including convulsions and eventual coma. Management of preeclampsia differs depending on the gestational age and severity of disease. For term pregnancies, delivery is the treatment of choice regardless of disease severity. For preterm pregnancies, in which delivery is not in the best interest of the fetus, patients with mild disease can be managed expectantly by closely monitoring the mother and fetus. However, eclampsia, severe preeclampsia with maternal end organ dysfunction, fetal compromise, or the HELP syndrome are indications for delivery regardless of gestational age. Antihypertensive therapy does not affect the disease course or improve outcome. Proteinuria and hypertension usually disappear within 1 to 2 weeks after delivery, except when they predate the pregnancy. Although in most instances preeclampsia has no lasting sequelae, about 20% of affected women develop hypertension and microalbuminuria within 7 years of a pregnancy complicated by preeclampsia. There is also a twofold increase in the long-term risk of vascular disease of the heart and the brain. Gestational trophoblastic disease. Gestational trophoblastic disease encompasses a spectrum of tumors and tumor-like conditions characterized by proliferation of placental tissue, either villous or trophoblastic. The major disorders of this type are hydatidiform mole, complete and partial, invasive mole, choriocarcinoma, and placental site trophoblastic tumor, PS. Hydatidiform mole. Hydatidiform moles are important to recognize because they are associated with an increased risk of persistent trophoblastic disease, invasive mole, or choriocarcinoma. Moles are characterized histologically by cystic swelling of the chorionic villi and variable trophoblastic proliferation. They are usually diagnosed during early pregnancy, average 9 weeks, by pelvic sonography. Molar pregnancy can develop at any age, but the risk is higher at the two ends of reproductive life, in teenagers, and between 40 and 50 years of age. For unknown reasons, the incidence varies considerably in different parts of the world. Hydatidiform mole occurs in about 1 in 1,000 to 2,000 pregnancies in the United States, but it is twice as common in Southeast Asia. Two types of benign, non-invasive moles, complete and partial, can be identified by cytogenetic and histologic studies. Complete mole. Complete mole results from fertilization of an egg that has lost its female chromosomes, and as a result, the genetic material is completely paternally derived, figure 2252AB. 90% have a 46 karyotype, stemming from the duplication of the genetic material of one sperm, a phenomenon called androgenesis. The remaining 10% result from the fertilization of an empty egg by 2 sperm. These may have a 46XX or 46XY karyotype. In complete moles, the embryo dies very early in development and therefore is usually not identified. Patients have 2.5% risk of subsequent choriocarcinoma and a 15% risk of persistent or invasive mole. Partial mole. Partial moles result from fertilization of an egg with 2 sperm, see figure 22. In these moles, the karyotype is triploid, e.g. 69XY, or occasionally tetraploid, 92, occasionally. Fetal tissues are typically present. Partial moles have an increased risk of persistent molar disease, but are not associated with choriocarcinoma. Chapter 22. The female genital tract. A. Complete mole, 23 times. B. Complete mole, 23 times or Y. Empty ovum. Chromosome duplication, 46XX. Homozygous complete mole, 46XX, 23 times or Y. Dyspermy C. Partial mole. 23 times or Y. Empty ovum, 46XY. Heterozygous complete mole, 69. The codes assigns for transactions where no currency is involved. 69, XXY, 23 times invasive mole. Invasive mole is an infiltrative lesion that penetrates or even perforates the uterine wall. There is invasion of the myometrium by hydropic chorionic villi, accompanied by proliferation of both cytotrophoblasts and syncytiotrophoblasts. In some instances, the villi invade perimetrial tissue and blood vessels and may even embolize to distant sites, such as the lungs and brain. However, these emboli do not grow, as do true metastases, and even without chemotherapy. B. Less commonly, complete moles arise from dyspermy, in which they eventually regress. The tumor manifests clinically with sperm fertilize an empty ovum. C. Partial moles arise from 2 sperm fertilizing a single ovum. Vaginal bleeding and irregular uterine enlargement. It is always associated with a persistently elevated serum HCG. Invasive mole responds well to chemotherapy but may result in uterine rupture, necessitating hysterectomy. Morphology: choriocarcinoma. Thin-walled, translucent, cystic, grape-like structures consisting of gestational choriocarcinoma is a malignant neoplasm of swollen edematous hydropic villi fix. 22.5 of swollen. In trophoblastic cells derived from a previously normal or complete mole, the microscopic abnormalities involve all or most abnormal pregnancy, such as an extrauterine ectopic prig of the villus tissue. The chorionic villi are enlarged, scalloped in Nancy. Gestational choriocarcinoma is an uncommon condition shape with central cavitation cisterns and covered by extensive scion that arises in 1 in 20,000 to 30,000 pregnancies in the trophoblast proliferation that involves the entire circumference of the villi. In contrast, in partial moles, only a fraction of the villi are enlarged and edematous, and the trophoblastic hyperplasia is focal and less marked than in complete moles. 23 times or Y dyspermy ovum 69XY rare, triploid partial mole. Figure 22.52 origin of complete and partial hydatidiform moles. Complete moles most commonly arise from fertilization of an empty ovum by a single sperm that undergoes duplication of its chromosomes. Grossly, hydatidiform mole appears as a delicate friable mass of. Figure 22.53, complete hydatidiform mole. Note marked distension of the uterus by enlarged vesicular chorionic villi. Adnexa, ovaries, and fallopian tubes are visible on the left and right side of the uterus. Clinical features: most women with partial or early complete mole present with spontaneous miscarriage or undergo curettage because of ultrasound findings of abnormal villus enlargement. In cases of complete mole, human chorionic gonadotropin HCG levels greatly exceed those of a normal pregnancy of similar gestational age. In addition, the rate at which HCG levels rise over time in molar pregnancy exceeds what is seen with normal single or even multiple pregnancies. Most moles are successfully removed by curettage. Patients are subsequently monitored for 6 months to 1 year to ensure that HCG levels decrease to non-pregnant levels. Continuous elevation of HCG may be indicative of persistent or invasive mole described next. Figure 22.5. Complete hydatidiform mole demonstrating marked villus enlargement edema and circumferential trophoblast proliferation. Readings 1035. A B. Figure 22. Choriocarcinoma. A. Choriocarcinoma presenting as a bulky hemorrhagic mass invading the uterine wall. B. Photomicrograph illustrating a tumor composed of neoplastic cytotrophoblasts and syncytiotrophoblasts. Courtesy Dr. David R. Genest, Brigham and Women's Hospital, Boston, Mass. United States. It may be preceded by several conditions. 50% arise in complete hydatidiform moles. 25% in previous abortions, approximately 22% follow normal pregnancies, with the remainder occurring in ectopic pregnancies. Gestational choriocarcinoma is rapidly invasive and metastasizes widely, but once identified responds well to chemotherapy. Rarely, non-gestational choriocarcinoma develops from germ cells in the ovaries or the mediastinum. These tumors are morphologically identical to gestational choriocarcinoma, but can be distinguished by the absence of paternally derived DNA, which is present in all gestational choriocarcinomas. Morphology. Choriocarcinoma is a soft, fleshy, yellow-white tumor that usually has large pale areas of necrosis and extensive hemorrhage. Figure 22, 55A. Histologically, it consists entirely of proliferating syncytiotrophoblasts and cytotrophoblasts. Figure 22. Chorionic villi are absent. Mitoses are abundant and sometimes abnormal. The tumor invades the underlying myometrium, frequently penetrates blood vessels, and in some cases extends out onto the uterine serosa and into adjacent structures. Clinical